Hello, my name is Ed Simcox, and I am the Chief Strategy Officer at Lifomic, a precision health and wellness company focused on applying scientific rigor and the most advanced technologies to help diagnose and treat illnesses, as well as give people agency over their wellness and their health status so they can live their healthiest lives. Prior to joining Lifomic, I was the Chief Technology Officer at the U.S. Department of Health and Human Services. I want to thank ACT and IAC for giving me the opportunity today to speak here at the Health Innovation Day 2020 event. I hope that my case study presentation today sheds new light on what I see as the most important issue facing our public health response to the pandemic. A call to action for industry to help the federal government address what I call the infodemic that accompanies the ongoing pandemic. Before we dive into the infodemic, I want to mention wellness data and how important personal wellness has become in the context of COVID. In the midst of this pandemic, we've all heard about how important it is to be healthy if you contract the virus. In fact, scientists believe the overwhelming majority of people that succumb to the virus have two or more comorbidities, meaning that they have underlying health conditions that prevent their bodies from mounting a healthy immune response to the virus so they can recover from it. Here at Lifomic, our two freely downloadable apps in the app stores focus on being mindful of health status and wellness, and we have seen almost exponential growth in the amount of users that we have across the world in the midst of the pandemic. In fact, we're just about to cross the 3 million user threshold, up from 1 million users just a few short months ago. And this has taught us how valuable data is to helping us during the pandemic. With this as a backdrop, I now want to turn our focus on what I believe we need to do as a nation to fix our broken public health data ecosystem. So we're obviously in the midst of a pandemic, but we're also in the midst of an infodemic. The term infodemic was coined in 2003 by David Rothkopf in a piece he wrote about the SARS outbreak in the Washington Post. Writing about the state of public health data during the SARS outbreak, he wrote, "The information epidemic, or infodemic, has made the public health crisis harder to control and contain. Infodemics are emerging as one of the most virulent phenomena known to man. They're able to transit continents instantly. In virtually every respect, they behave just like any other disease, with an epidemiology all their own, identifiable symptoms, well-known carriers, even straightforward cures. Yet, to date, many in power seem unable to contain them or are unwilling to acknowledge their existence. These internet or media-borne viruses create global pandemics, trigger irrational behavior, blur our vision of important underlying problems, strain our infrastructure, buffet markets, and undermine governments. So here we are, 17 years later, much further into the so-called information age than in 2003 when the SARS outbreak occurred. Today in the US, there's no standardized reporting of public health data. It comes in from a variety of sources in different formats at different times. Sometimes it doesn't come in at all. State and federal agencies have different reporting formats they impose on local public health offices and healthcare providers. And as we sit here today, essential healthcare workers are spending precious time retyping data into systems from printed reports and PDFs. So why not just create a centralized cloud-based system into which all data must be reported? At the heart of the lack of a centralized data infrastructure for reporting public health in the United States is the 10th Amendment to the U.S. Constitution. The 10th Amendment says, "The powers not delegated to the federal government by the Constitution are reserved to the states." Thus, the federal government, including the CDC, are not able to mandate that states use a centralized reporting mechanism to input COVID data. The CDC has been left in a position where it's necessary to beg states for data in many cases. Further, the 10th Amendment means that states are able to set up their own IT systems separately from all other states and the federal government. This leads to bespoke, disparate information systems in each state and territory, as well as some larger cities. Congress's response to the recurring pattern of epidemics like SARS was to examine the state of public health data systems in the United States. In 2006, Congress passed the Pandemic and All Hazards Preparedness Act. The act required the CDC to establish near real-time electronic nationwide public health situational awareness capability. 4 years later, in 2010, the Government Accountability Office reported that not even the most basic steps had been taken to establish such a network. Then again, in 2013, Congress passed the Pandemic and All Hazards Preparedness Reauthorization Act and reiterated the mandate for a near real-time interoperable public health network. The Government Accountability Office once again reported in 2017 that the CDC failed to implement the statutory requirements. This all too familiar pattern was once again repeated in 2019 when Congress passed the Pandemic and All Hazards Preparedness and Advancing Innovation Act. The law was enacted in 2019, right before the pandemic started, and our need for such a system is now greater than ever. So how do we move forward? Now that I've framed the issues that have prevented us from using public health data to best address the current pandemic, and talked about attempts by Congress to address the situation, I want to now turn to what I think is the best way to address it. I believe that HHS needs to lead the charge in creating a modern approach on behalf of all public health agencies throughout the United States, including the CDC. HHS was given $1 billion in the recently passed CARES Act for public health data infrastructure modernization, and only a fraction of this money is needed to solve the issues that I've discussed. First, let's talk about data flow and linkage. While we do have data, we need that data to be more complete, timely, and accurate. We need to encourage state and local health organizations to use a standardized approach to collecting data at the point of testing, the point of care, and the point of immunization. To link disparate data sets, we need a federal data gateway to allow for the secure flow of data between all of the components of the public health ecosystem. The idea is not to create a massive data warehouse, but to allow data to be queried and reported between all stakeholders. The idea is also not to create new bespoke systems, but to create a single gateway system at the federal level that stitches all existing data systems together using modern application programming interfaces, or APIs for short. Such a system will allow data to flow between jurisdictions and up to the CDC so that we can do a better job using data to inform public policy. We should leverage recently adopted interoperability standards to acquire data from existing electronic health record systems, or EHRs, wherever possible to avoid duplicate entry of data by essential workers in hospitals and healthcare providers. Health insurance claims data can also be very useful in understanding the pandemic. Fortunately, the public health data interoperability challenge can be solved today. HHS has partnered with the private sector the past few years to solve health data interoperability at large and data movement by supporting the private sector's move to a standardized model for healthcare data. Congress has spent billions of taxpayer dollars creating an environment for health data interoperability between healthcare providers such as doctors' offices and hospitals, most recently as part of the 21st Century Cures Act, which just saw its regulations go into effect this year. Healthcare providers are busy preparing to accommodate the Act's new standards and requirements. And I believe the federal government should eat its own dog food here by adhering to the same standards when creating this new gateway. The two main standards to pay attention to here are the Fast Healthcare Interoperability Resources, or FHIR, FHIR, and the United States Core Data for Interoperability, or USCDI. These two widely accepted standards can immediately begin supporting such a new gateway. So I just discussed the importance of setting up a new gateway model for the movement of public health data in the ecosystem. I also discussed the importance of standardization and the ability for us to use widely accepted standards that can be easily extended to solve public health data interoperability. Once data is available and flowing, we need a cloud-based data hub to begin gaining insights from COVID infection rates, vaccinations, and many other key indicators important to recovering from the pandemic. While HHS has made good forward progress with what they call HHS Protect Data Hub that was established to address COVID, it's largely a stopgap solution that uses proprietary, labor-intensive tools and lacks some of the well-known tools of modern data research and reporting environments. As mentioned before, the $2 trillion CARES Act called for $1 billion to address U.S. public health data infrastructure. The good news is that a new, robust, cloud-based data hub would cost a tiny fraction of that. And with a concerted effort from HHS, OMB, and the White House, this new system could be set up within months. There are well-known tools and virtual computing environments that could be put to use right away. A modern data hub would benefit not only the federal government, but also the research community and academia, as these organizations play very important roles in helping us further understand the pandemic and the behavior of the virus. Most importantly, such a hub would provide transparency and accountability, giving confidence in the data being reported. Finally, such a data hub becomes even more important as we begin to distribute and administer vaccines to hundreds of millions of Americans across the United States. We need to know who is getting the vaccine, how efficacious these vaccines are, and how quickly they are being deployed. In summary, the keys to addressing COVID lie in our ability to collect complete, timely, and accurate data, transit that data through a secure gateway, and then analyze the data in a state-of-the-art data hub to best inform public policy. If done right, we will then have a durable system well equipped to address future public health hazards. Again, thank you very much for having me today, and I'll be happy to take any questions.